Hi folks, my name is Keith Lamb. I'm a respiratory therapist in Charlottesville, Virginia. I was asked to talk about hot topics in respiratory critical care. In terms of conflicts of interest, I really don't have any. I am the Chief Executive Officer and co-founder of Inspire Respiratory Critical Care, which is a philanthropic nonprofit organization that seeks to close the gap between the science and bedside care. And so in order to do that, we produce a lot of educational material, provide a lot of panel discussions. We have a podcast. We do virtual classroom lectures and lots of other things. You can go to www.inspire-rt.com to find out more about us. So to start out, I'd like to start with a short story that I think lays sort of a foundation regarding what today's paradigm shift has become and what our standards have become in terms of respiratory critical care. So a while back, a young man was watching his father prepare dinner one day, walks into the kitchen. His father's trying to prepare a oven roast for dinner, and he watches his dad, and his dad lops off the ends of the roast. And the young man says, "Dad, why would you lop off the ends of that roast?" And so the dad says, I don't have any idea why I do that. Let's ask your grandma because she taught me how to do that. So they call the grandma up and they say, "Grandma, why did you teach Dad to cut the ends off of this roast before cooking it, before putting it in the pan?" And she said, "I honestly don't remember. My mom taught me to do that." So they got great grandma on FaceTime, and they said, "Great grandma, why did you cut the pot roast, the ends off of the roast before you put it in the pan?" And she said, "Because our pan was too small." And so this is a good example I like to use as an example as to why the excuse or the explanation of "that's how we've always done it" is inappropriate and shouldn't be used. And I think a lot of times people sort of take the easy way out and just, instead of explaining why something's done, they just say, "Well, this is the way we do it." And so what I want you to get as you listen to this talk and as you reflect on the information that I try to pass on to all of you today, I want you to think about progression and closing that gap between the science and clinical practice at the bedside, and what things that we used to do that we no longer do. Some of these things might have made sense way back when they were done, and yet now it doesn't make any sense. You can get a pan that's bigger than the roast. So this is way back when. Again, another example of the way we've always done it. Anybody who's been practicing respiratory therapy as long as I have, it's about 28 years now. We'll remember back when anesthesia used to use very large tidal volumes and no PEEP intraoperatively on many patients, and that sort of filtered out to everyone else for a while. But we know now that, and we'll talk about this in much more detail here shortly, but we know now that that's probably not the best approach. So this was the very first anesthesiologist here. So hot topics in respiratory critical care, the paradigm shift over many years has become to not hurt the patient. Modern critical care is less about how can we help the patient and more about how can we prevent causing harm. Something I like to tell teams, respiratory therapy teams, because respiratory therapists are uniquely positioned to impact patient outcomes. Nobody's more uniquely positioned or better positioned to affect outcomes than that bedside respiratory therapist. And so I want you to remember that when you are at the bedside. Now, when I say impact patient outcomes, you can impact them either way, right? You can make them good or you can make them bad, but nobody is better positioned or has more responsibility than the bedside respiratory therapist. A quote from Alvin Toffler from a few years ago: the illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and then learn again or relearn. Truer words have not been spoken. So our outline today, we're going to talk about, we have to really lay a good foundation before we can talk about hot topics today. We have to talk about how we got here. And so we'll do that. We'll talk about ARDS, mechanical ventilation, proning, non-invasive support to some extent, pharmacology, extracorporeal support, hot topics, and then discussion period. Way back when, many years ago, the Berlin definition was established, and this gave us a really good foundation on what is acute respiratory distress syndrome. And I talk mostly about ARDS because that seems to be the central issue that we deal with in modern day ICUs. And so it's important to understand what it is and how it develops and what its characteristics are. And when the Berlin definition was established, they got rid of acute lung injury. That was part of the old definition. So it's all ARDS, mild, moderate, or severe. You can see the different characteristics here in terms of oxygenation. PF ratio of less than 100 is severe, 100 to 200 is moderate, and above 200 is mild ARDS, but less than 300. Just a couple of years ago, a bunch of people got together and developed a new global definition of acute respiratory distress syndrome. And the advantages to this new definition are that it really allows people that have fewer resources to still be able to define ARDS in their patient population. So no longer is intubation required. The original definition, the patient had to be intubated. Now, according to this new global definition, they can be on high flow nasal cannula as long as the flow rate's greater than or equal to 30 liters. They can be non-invasive as long as the index pressure is greater or equal to 5. No longer need an arterial line to calculate a PF ratio. You can use the SF ratio, which is got good correlation. And bilateral opacity is confirmed by one of the following. Normally we use a chest film, but what this new definition allows is for the use of point of care ultrasound or POCUS by a well-trained operator. And in resource limited settings, the following are not required: PEEP, oxygen flow, or specific respiratory support. Primary ARDS can be pneumonia, aspiration, pulmonary trauma, contusions, drowning, inhalation injuries, fat emboli, reperfusion injury, and probably some others. But number one cause of primary ARDS, meaning that the ARDS originated, the issue originated in the lungs and then potentially gets other organ systems involved, but it originates in the lungs, and pneumonia is probably the number one primary source of ARDS. Secondary ARDS, sepsis, shock, trauma, pancreatitis, etc., where the issue originates in another organ system and then involves the lungs via circulation through the pulmonary system and inflammatory involvement. These are images of the alveolus. You can see the normal alveolus up top left of your screen. And then finally, where there's an injury and there's leaky capillaries, and all these inflammatory mediators are leaked into the system and circulated systemically. And these inflammatory mediators really play havoc with this system. This is an example of an inflammatory process. You know, if you step off the curb and roll your ankle and sprain your ankle, you can see this inflammation here. This is visual inflammation, but what's going on the inside is the same thing that goes on with ARDS and the inflammatory mediators and the cascade that originates because of an injury, either primary or secondary, like we've discussed, and starts to invade the area of injury. And in the case of a sprained ankle, these inflammatory mediators, or in the case of an infection, these inflammatory mediators are probably beneficial. But in the case of ARDS, where this causes excessive accumulation of fluid in the alveolar space and the perialveolar space, then it impedes gas exchange and it's not beneficial. If you ever sat somewhere kind of fidgety and played with a paper clip and bent it, if you know that if you keep bending it, then it will fracture. And the same thing happens with that alveolus that has such a thin layer. It's a one cell layer thick wall around that alveolus, and so it's very fragile. This is what it looks like. We know what this unidimensional chest imaging and multidimensional high definition CT scan looks like. A few years ago, in 2016, LungSafe observational study was published, and basically almost 30,000 patients. So a lot of patients showed that what it showed was that we weren't that good at identifying ARDS and then implementing the appropriate evidence-based strategies that we should have been. So almost 30,000 patients, 30% of those patients that had ARDS had mild, 47% had moderate, and severe 23%. 10% of ICU admissions overall out of all these 29,000 were ARDS patients. What we found out with this study was that we were horrible at recognizing ARDS. Only 50% in mild and 78% in severe ARDS were actually documented in the chart and identified as having ARDS. Less than 2/3 of all ARDS patients received tidal volumes of 8 milliliters per kilogram predicted body weight. This was 2016. The ARMA trial in the year 2000 taught us that smaller tidal volumes, 6 to 8 milliliters per kilogram of predicted body weight, were probably safer and for sure reduced mortality or improved mortality benefit. Plateau pressure was only measured in 40%. PEEP of 12 or less was used in 83% of ARDS patients. Again, we'll talk about this data and the science behind this throughout this presentation. But you gotta think when you see that number that people were not using the appropriate amount of PEEP. Prone positioning was used in only 16% of severe ARDS. Clinical recognition of ARDS was associated with a higher PEEP. Once we did realize that somebody had ARDS, then we used higher PEEP. Hospital mortality was 35% for those with mild ARDS, 46% with those in moderate to severe ARDS. So what this tells us is this is a global evaluation and observational study of a whole lot of ARDS patients, and what the central theme here is, or what you should get out of this, is that no matter where you are in the world, you could be in Charlottesville, Virginia, you could be in Philadelphia, Pennsylvania, you could be in Bangladesh, you could be in Shanghai, it doesn't matter. If somebody has moderate to severe ARDS, their mortality is about 40%. So if our mortality is about 40%, and this is a really important point, so pay attention. Overall mortality is about 40% for moderate to severe ARDS. The interesting thing is, and the thing that's really important to understand, is that only 1 out of 10 of those patients that don't survive ARDS don't survive because of hypoxemic respiratory failure. And if you remember If you think about ARDS, that's most likely the reason why they got intubated. I mean, there are ARDS patients that get intubated for other things, if they're trauma and it was for airway protection, etc. There are other reasons, but likely most of these patients that get intubated because they have hypoxemic respiratory failure, which is sort of the hallmark of ARDS. So if only 1 out of 10 of these patients that don't survive ARDS die from hypoxemic respiratory failure, what do the other 90% of this 40% die from? And that is multi-system organ failure. So I showed you that sprained ankle, and I showed you those fractured paper clips, and you've seen the imaging of ARDS. You can imagine that inflammatory cascade that goes to the lungs from this lung injury and then is exacerbated by positive pressure ventilation, which is the crux of protective support for ARDS patients. Then if we don't follow those rules, if we don't pay attention to the potential for lung injury from the things that we do for the patient or the things that we think we're trying to do for the patient, then that can precipitously increase mortality on these patients. So 90% of this 40% that don't survive die from multi-system organ failure, and a large percentage, and we don't know what that percentage is, but we know that it's a large percentage of those patients that die from multi-system organ failure die from iatrogenesis, and meaning that things that we are doing to the patient, and a great deal of those patients die from inappropriate ventilator support. Mechanical ventilation, we talk about oxygenation here. If I took you and we chartered a bus, all of us, and we drove up to Boston, and we went to Harvard University, and we went to their library where very, very smart librarians work, and we asked them to pull all of the papers that support the notion that if I improve somebody's gas exchange, that I improve mortality. In other words, if I can do something, if I can implement something, and I can take their PO2 of 40 and I can make it 140, what impact does that have on survival of the patient? And so if I ask you to do that, then the librarians would really have a tough time finding any data that supports that notion. In other words, it probably doesn't matter what your PO2 is to some extent. This study just came out recently in 2021 that showed that there was no mortality benefit if you targeted a PO2 of 60 versus a PO2 of 90. No mortality benefit. Remember the ARMA trial, the ARDSNet trial, that compared the control group was 12 milliliters per kilogram of predicted body weight, and the study group was 6 milliliters. Mortality benefit decreased by greater than 20%. So mortality was improved. The mortality benefit was that it was decreased by 20%. And interestingly enough, in the control group, the PO2 was higher. If you remember the ARMA trial or the ARDSNet trial, in the control group with the higher tidal volumes, the actual PO2, the median PO2 was higher in that group. These are two male, 5'9" males, and if you follow the predicted body weight and tidal volume charts, and you were taking care of both of these patients, and since they're both 5'9" and they're both males, the tidal volume would be about 424 milliliters in order to follow that 6 milliliters per kilogram predicted body weight. So 424 milliliters in both of these patients, if you're sort of blindly following the tidal volume chart, then they would both get the same amount of tidal volume. Clearly, if you put 424 milliliter tidal volumes in the patient on your right versus the patient on your left, that would have different consequence, right? There is less room for that tidal volume to go in that patient on the right than there is on the left. And so because of that, more tidal volume would go into a smaller space that's available. Volume takes the path of least resistance, volume, pressure, and flow does. And so you would get more stress and strain and potentially more of that secondary inflammatory cascade that we've been talking about, that sprained ankle, that inflammatory cascade with all those mediators circulate systemically and involve other organ systems. So should you use the same tidal volume in each one of these patients? Probably not. If we look at Dr. Marcelo Amato's work from 2015, where he looked at driving pressure and survival in acute respiratory stress syndrome, he looked at a bunch of papers. Definition of driving pressure is the difference between plateau pressure and PEEP. So if we take a plateau pressure measurement and we subtract the PEEP, that is your driving pressure. And what he did was he looked at several, 9 actually, major previously reported ARDS trials with a total of 3,562 patients. And he looked at all of that data, and by all the data, it's an impressive list of the number of data points that he looked at. But if he looked at all of that data, and what he realized was independent of tidal volume measurements, any other criteria that we look at, independent of all of those, the thing that had the best correlation with mortality was driving pressure. And where you see that red arrow there is about 15 centimeters of water. So where you see that red arrow, there's a precipitous increase in mortality where there's an incremental increase in driving pressure. So where that point sort of takes off is at 15 centimeters of water. So it's been standard to pay attention to driving pressure, and there's probably benefit to making sure that you keep that driving pressure less than 15. So the learning points that, or the pearls that came out of this fairly large patient population, 3,500, was that if I'm at the bedside, I'm taking care of a patient, and I'm manipulating the ventilator, I'm managing the ventilator support, and I make a change that increases driving pressure with a fixed PEEP level. Okay, what kind of change might that be? If I go up on tidal volume, and that makes the driving pressure go up, and the PEEP level stays the same, I haven't touched the PEEP, that will lead to a higher mortality. That will lead to more people not surviving. If I increase the PEEP with a fixed driving pressure, in other words, whatever mode of ventilation, and I increase the PEEP, and as a result of that increasing the PEEP, the driving pressure doesn't do anything. It doesn't go up, it doesn't go down, it stays relatively similar, then that probably has very little or no effect on mortality. If I increase the PEEP and that leads to a decrease in driving pressure, I'll say that again, if I increase the PEEP and then I measure the driving pressure over a period of time and the driving pressure goes down, then survival improves. And the likely explanation for that is because if I increase the PEEP and I recruit alveoli, I recruit functional alveoli, or I make dysfunctional alveoli functional, and I provide more space for that volume. Remember those two CT scan slices? If I make more space for that volume, then it's likely I'm going to exert less stress and strain on functional alveoli or healthy alveoli, and I'll have less of that secondary inflammatory process. We know that there is a significant increase. I showed you the data, 3,500 patients. We know there's a significant increase in mortality once driving pressure is greater than 15 centimeters of water. So you should be checking this on your patient every time you see them. Individualizing people, we know that there is a huge push, and this is a hot topic today. There is a huge push to personalize medicine, precision medicine, medicine based on the patient that's in front of you, not necessarily an aggregate, right? We get our science and our data from aggregates, but we need to fine tune that, and we need to, do things for the patients in front of us because they're not all the same. Big push in looking at biologics, mechanics, ventilator settings, and sort of using that data in AI to personalize and provide precision medicine. We don't know the best way to determine PEEP. There are a bunch of different ways that people use. PEEP at 502 tables, esophageal manometry, CT scans, ultrasound, EIT, BMI, mechanics, recruitment to inflation radios, driving pressure. I just showed you a bunch of data that supports that. And sort of, in my mind, is sort of intuitive that, that driving pressure, the higher that driving pressure, the more stress and strain and injury that I'm probably causing to the lungs and more specifically the healthy functional lung. Mechanical power, I'm not going to talk about it. I want you to understand. I don't want you to memorize the formula. If your professors are asking you to memorize that, then of course you need to do that to pass tests. What I'm telling you is that it's less important to memorize the formula and more important to understand what it is. And what it is the amount of energy that's being transferred to the lung units. And so you should consider that and understand what makes the energy go up that you're causing the lungs to be exposed to. So what does that mean? What are those things? Stress, strain, frequency. If I increase the rate, if I leave the tidal volume the same but I increase the rate, then the mechanical power goes up. The energy that I'm causing or exerting against the alveoli goes up. If I leave the rate the same but I increase the tidal volume or I increase the driving pressure or the pressure, then the energy goes up. Probably goes up less when I increase rate than it does if I increase driving pressure or volume, but it goes up the same. It goes up as well. If you think about this, if my driving pressure is greater than 15, we know that that's injurious. If I have a driving pressure of 15 and I have the ventilator set at 30 times a minute, then that's worse than 20 times a minute. So all these things sort of have to be understood. You wouldn't ask somebody that's, if a person that's got that sprained ankle is given the option of jumping up and down on it 10 times a minute versus 30 times a minute, then I'm going to guess that they would do it 10. And it's for good reason, because there's more energy exerted the more often that you expose the injured body part. Way back 2012, we kind of got rid of the oscillator in adult patients. One of these big trials, both these trials were published on the same day in New England Journal of Medicine, and one was stopped for futility and the other one was stopped because it appeared that there was more risk and more harm in the oscillator trial. Recruitment maneuvers got popular for a short period of time, but we know that these should not be routinely done in ARDS patients. We think that recruitment maneuvers cause more stress and strain and injury to functional, non-affected or unaffected alveoli and ARDS. There is a study called the ARDS trial, that this trial here that demonstrated that 28 day all-cause mortality was increased when lung recruitment maneuvers were routinely done. So don't do them. Recent CPG, or clinical practice guideline for liberation from ventilator, also a hot topic of sorts. They came out and said, hey, you know what, RSBI is probably not needed to determine whether or not somebody's ready for an SBT. The SBT is probably the most important part of the process. And just as sort of a side note, we just recorded a podcast with an intensivist in our podcast is called the Gas Exchange. You can find it on Spotify, YouTube, and Apple Podcast. We just interviewed an intensivist in Paris, and throughout the discussion, we realized that there are many parts of the world that don't do a spontaneous breathing trial at all, and many of them have just as good outcomes as anybody else. However, here, the standard is to do a spontaneous breathing trial. You don't necessarily need to do an RSBI to determine safety for the SBT. Probably doesn't matter what kind of support you use. Probably low levels of pressure support have better outcomes. It's probably more important to make sure that you do the spontaneous breathing trial the same way on patients, so that if I come in and do one day on 5 of pressure support, and you come in the next day and do them on CPAP, you really can't tell if there was improvement, if the patient's better or worse or the same. They recommended the FiO2 should not be increased during SBT, although there's some controversy about this, not good data, and they even admit that conditional recommendation, very low certainty. Prone positioning, we know this works in multiple different ways. We have, at the very beginning of this presentation, we talked about how just because you do something to improve somebody's PO2 doesn't correlate with better outcomes. And that's the same thing with prone, even though a large percentage of patients that you prone, their PO2 improves. But what we think is the benefit is that you redistribute transpulmonary pressures and exert less stress and strain on functional alveoli again. And so this sort of has become a theme, if you will, and you should really pay attention to it. So prone positioning does improve outcomes. The PROCEVA trial told us that if somebody had a PF ratio of less than 150, and if you prone them for at least 16 hours at a time, that their outcomes were significantly improved. As a matter of fact, that there's not much out there that shows more of an improvement in outcomes than prone positioning. Non-invasive support, historically we've used non-invasive support for multiple different patient types. People with chronic obstructive disease, type 1 and 2 respiratory failure, hypoxemic hypocarbia, congestive heart failure, chest trauma, neuromuscular disease, post-extubation patients with a high risk for reintubation. This is a very hot topic and something that's discussed on a large scale. The use of nasal high flow oxygen. So just to sort of, we're talking about non-invasive support, which means that it's not invasive, right? And so non-invasive support can be BiPAP, CPAP, high flow nasal cannula. In some cases, negative pressure ventilation maybe, although we don't talk about that right now in terms of something that we would do and that we would use routine in critical care. So if you look at the reviews, there are all kinds of reviews on high flow nasal cannula. There's all sorts of benefits from them. I love using high flow. I extubate a lot of patients to high flow. The benefits are, like I said, multifactorial. You can reduce their work of breathing by increasing their FRC. You deliver appropriately heated and humidified gas, and so that reduces the injury to the cilia, to the gel layer and the mucus layer of the airways, and so the cilia can keep on doing their thing. You do provide some positive expiratory pressure. I wouldn't call it PEEP, but because it's variable based on the cycle of the patient. However, it does provide some positive expiratory pressure, and you can certainly provide more accurate FiO2. High flow nasal cannula versus bag valve mask shows that when it's been studied, shows that you can use it for pre-oxygenation before intubation. It's safe. There's no significant difference in mean SpO2 between groups. However, there was a significant decrease in SpO2 during the apnea phase before intubation in the bag valve mask group versus and was not seen in a high flow nasal cannula group, which honestly, for pre-intubation, pre-oxygenation, the whole purpose of doing that anyway is to prevent large dips in oximetry and oxygenation during the apneic period of RSI. Direct extubation to high flow, very common these days. We know that it's been studied by many people. High flow nasal cannula is reliable alternative to non-invasive ventilation. No significant differences in reintubation rates between the two groups. High flow nasal cannula seems to be an effective strategy for managing obese patients. We know that obese patients are morbidly obese patients are certainly a whole class in of themselves with mechanical ventilation and non-invasive support. Back in early COVID, people who routinely used high flow nasal cannula started to turn the flow down, concerned about cross-contamination to their team members. And so this was studied pretty quickly, because what we realized was that people were turning the flow down to 15 liters a minute on these high flow devices. And of course, that's not high flow. The median inspiratory flow requirement for an ICU patient's inspiratory flow requirement is 20 liters or more. So if you have it set at less than 20, you're not providing high flow. But nonetheless, this was studied, and there was actually less cross-contamination and dispersion of contaminants in the high flow nasal cannula than almost all of the other potential devices. Pharmacology, some of the important stuff. Review of inhaled nitric oxide and aerosolized EPO in acute lung injury or acute respiratory distress syndrome back in 2014. So this is quite old now in terms of age of trials. But this trial back in 2014, I'm going to show you a newer one here in a moment, showed that in almost every one of these studies that was evaluated for this analysis, outcomes were worse in the patients with ARDS. Now, so we need to be clear what kind of patients we're talking about. These are patients that have ARDS, hypoxemic respiratory failure, okay? Specifically adults with hypoxemic respiratory failure. And the outcomes in inhaled nitric oxide were either worse or the same, and in inhaled EPO, they were also either worse or the same. Now, this is a bigger look at this issue and a more recent look. And basically what this Cochrane review came up with was evidence is insufficient to support inhaled nitric oxide in any category of critically ill patient with acute hypoxemic respiratory failure. Inhaled nitric oxide results in transient improvement of oxygenation. We've already talked at length now during this presentation about how improvement in oxygenation does not correlate with an improvement in outcomes, except for that very tiny subset of patients, that 1 out of 10, excuse me, that don't survive from hypoxemic respiratory failure. Okay, but it's a very small group, and of course, I there's no way I could argue against starting something like inhaled nitric oxide in a patient that has a PO2 of 30, and so I wouldn't do that. But overall, patients with acute hypoxemic respiratory failure do not do better when inhaled nitric oxide is delivered, and as a matter of fact, they oftentimes develop renal failure. Examples of patients this might not pertain to are patients who have some sort of mechanical cardiac issue. A mechanical cardiac issue would be something like a patent foraminal valve, right? And so we know if you look at that heart diagram there, and you look at the four chambers of the heart, I like to use numbers that are very easy to remember and they math up nice. Is right atrial pressure of 5, left atrial pressure of 10, right ventricular pressure of 25, and left ventricular pressure or systemic pressure of 100. And that's sort of close to what median normals would be, right? If something happens to increase pulmonary vascular resistance, right? Pulmonary vascular resistance, and my RV pressure goes up to 100. If you look at this diagram, the numbers are changing. And if that number, my RV pressure goes up because of an increase in pulmonary vascular resistance. And what's a common cause of a sudden increase in pulmonary vascular resistance? It could be a big pulmonary embolus. Right? A big pulmonary embolus would include enough pulmonary vasculature to cause back pressure in the RV. Hypoxemic vasoconstriction causes this issue, right? So if there's enough of it, and that RV pressure goes up, and as a result, the RA pressure goes up, look, it's up to 25 now, then you can get blood that crosses that PFO to the left side of the heart that now never takes place in gas exchange whatsoever. And so that's a problem, right? And that's where inhaled pulmonary vasodilators may have some benefit in critically ill patients. So there are some newer hot topics with inhaled nitric oxide. So I just showed you what could do for PFO. Nitric may have antibacterial properties when given in massive quantities. May preserve ECMO circuits integrity and allow for fewer circuit changes because of its effect on platelet aggregation. So don't tell anybody I told you to never ever use nitric oxide. Steroids for treatment of ARDS, early administration of dexamethasone could reduce duration of mechanical ventilation and overall mortality in patients with established and severe ARDS. If you look at this meta-analysis, you see all the papers on the left side show a benefit from using corticosteroids in ARDS. All of these papers show a benefit in using neuromuscular blockers or paralytics. And again, the details matter, right? And so what you'll find when you look at these papers and this data in its granularity, or its very, not from this 20,000 foot view that we're looking at here with this analysis, but when you look at these papers and their finer detail, you'll realize that, again, the patient matters, right? The patient matters. And so if it's a patient that's really sick, PF ratio is less than 150, some people say less than 100, so significant hypoxemic respiratory failure, and if it's implemented early on, then there may be mortality benefit. And one of the mortality benefits, even though when we paralyze somebody, typically their PO2 gets better, but we know that doesn't mean anything necessarily. But one of the other benefits is that the patient is no longer spontaneously and vigorously breathing and causing their own patient self-inflicted lung injury. And we're going to talk about that soon. ECMO extracorporeal support, EOLIA trial back in 2018 showed that there was certainly some mortality benefit to being placed on extracorporeal support early. Extracorporeal support for refractory out of hospital cardiac arrest. We know that now, so when you talk about cardiac arrest is a whole different critical care topic, right? And it's a hot topic, and people are talking about it a lot. But the endpoints may be different. The endpoint there, something I like to say in critical care is there are worse things than dying, right? And one of those worst things than dying could be that you survive, but your functional and cognitive ability is so significantly changed that you are no longer the same person than you were before you suffered this cardiac arrest, and that might not be a favorable outcome. Cognitive and neurologic outcomes in patients that received ECMO or extracorporeal life support for ECPR were better. Better enough, in fact, that the AHA has named and categorized ECPR as a 2A recommendation. And so that recommendation has the same validity and same evidentiary support that giving epinephrine has. ECMO and COVID, 3 prospective trials, bunch of retrospective looks at this, and some case reports. And they looked at COVID-19 versus influenza ARDS, a bunch of patients, mortality 39%. So mortality, as it relates to ECMO and COVID ARDS, was the same as it was in the EOLIA trial, and also the same as it was in the Caesar trial, which was a study a few years ago that looked at transferring patients from smaller centers to tertiary centers where they might not have gotten ECMO, but they just got better critical care because there were more experienced team members there. More hot topics for today. I mentioned PSRC. What this means is that whole mechanical power, that whole energy, that whole stress and strain doesn't necessarily have to be produced by the ventilator. It can also be produced by the patient themselves. And so they can cause their own larger pressure swings. And this may be why there's some outcomes benefit from using neuromuscular blockade early on. They can produce their own pressure swings. They can cause their own injury. They can cause their own inflammatory process. And we really need to pay attention to that and balance that with the knowledge that we have that we should be using less sedation and extubating people sooner. Esophageal manometry might be a really good way of setting positive and expiratory pressure and maybe monitoring transpulmonary pressure. We know that it helps partition the pressures that are inside the lungs with those that are outside the pleural space, like abdominal compartment syndrome, morbid obesity, things like that. Could be helpful to assess for appropriate PEEP levels and sometimes support the notion that you should extubate patients from higher levels of PEEP. It's a focal measurement. It can also be used to measure work of breathing and is expressed in joules or energy. Practical applications for esophageal manometry will help sort out injurious ventilator settings, descending pressures, and determine an appropriate amount of PEEP. Uses a 5 French, well, they're not all the same now. This is an old Cooper catheter, Cooper surgical catheter, 5 French that we used to use commonly for measuring esophageal pressure. Some of the data is really good. If you look at all of the data points on the right side of that vertical axis, these all support the use of esophageal manometry to set positive and expiratory pressure. EIT, getting really popular now. This is a really good way to individualize or personalize care to the patient because you can see in real time by using multiple ultrasound type probes to look at lung parenchyma while you make ventilator changes. This could be a really good way to individualize PEEP. Again, you use a belt like this, and there's only a couple systems available out there. They're similar. You use these little ultrasound probes to go ahead and make these images, and you can see these different images at different levels of PEEP. And the idea of really finding that sweet spot where you're not over distended, where you're distended just the right amount, right, so that you don't have adduct trauma and you don't have over distension of healthy lungs, but you're recruiting best you can. Diaphragm is king, man. We have learned so much stuff in the last couple of years about how over support from the ventilator, under support of the ventilator can cause ventilator-induced diaphragm dysfunction. And once that happens, and it happens in about 20% of the patients that you have trouble liberating from the ventilator, actually have ventilator-induced diaphragm dysfunction. And so that's something to really be aware of. And it has the pathophysiology of this is really very similar to ventilator-induced lung injury. 80% of everybody you intubate have some sort of ventilator-induced diaphragm dysfunction at the end of the day within the first 24 hours. So this is a big deal. We don't know exactly how to avoid it. We know that it's probably most prominent in patients that get over supported with the ventilator. So spontaneous breathing, getting those patients on pressure support as soon as possible, it really is important. But we don't have this completely ironed out yet. P01 is a marker and measurement of respiratory drive. And so if you're trying to prevent P-cili or that excessive drive from the patient, that excessive effort from the patient, then this is a good way of looking at that. Most ventilators will measure this for you. Some of the ventilators don't, but I think most of them do. And so if the unique thing or the difference between just doing an expiratory hold and doing like a NIF, for instance, the difference is that the P01 is measured right at the beginning during the first 100 milliseconds. And so it occurs before the patient has time to become distressed during an occlusion maneuver. And so we know that patients that have, P01s, normal P01 is probably 0.5 to 1.5. So if it's higher than that, then that may be excessive effort, and you may need to do something like increase support. And even with ARDS patients, it's even higher. So you should really you should look at that, monitor it, and potentially try to mitigate those numbers. Point of care ultrasound is very popular these days. Lots of RTs are doing this to look at diaphragm thickness to evaluate for ventilator-induced diaphragm dysfunction is a big one. Arterial access is another big one. And so POCUS can be used for all sorts of different things. But from an RT standpoint, A-line placement, difficult ABG sticks, and diaphragm thickness to evaluate for VID. Recruitment to inflation ratio, you can look at the steps here. I believe that these slides will be made available to everyone that would like them. You can look at this, but it's a way of determining whether or not there's recruitable lung, right? Because if there's not recruitable lung, then the things that we do to recruit are potentially injurious. If there is recruitable lung, then the things that we do to recruit lung is beneficial and may have outcomes benefit. So this number, once you evaluate it, normal range is 0 to 2, with the higher values indicating a greater potential for recruitment, and the lower numbers, like less than 0.5, show that there's very low recruitability. And if there's low recruitability, then you shouldn't be doing things like increasing to really high levels of PEEP. So finally, we're going to wrap this up with Lamb's rules of mechanical ventilation. Now, these aren't obviously my rules. These are the rules that we have extrapolated from the science and the evidence and the data. And so number one, start tidal volumes out at 6 milliliters per kilogram predicted body weight. Target that amount, and no matter what mode of ventilation you're using, we're not going to talk about modes of ventilation today. Dose the ventilator to the patient. So once you, and a good time to do this is right after you intubate them and they're still paralyzed from the RSI meds. You can get some really good static measurements. Dose the ventilator to the patient. Keep that plateau pressure less than 30. Keep the driving pressure less than 15. Use PEEP in recruitable lungs to allow for lower FiO2 and to prevent iliac trauma. Use modes of ventilation that promote synchrony. Not all asynchrony is injurious necessarily. We're not 100% sure about that, but certainly makes sense to reduce asynchrony when that's possible. Always attempt to make the ventilator fit the patient, not the other way around. Your approach should not be to make the patient fit the ventilator, right? Because to do that, you need lots of medicine. Prevent over and under support. Use numbers like P01. Use your clinical assessment skills, your clinical reasoning ability, and look at the patient. Are they being over-supported, over-sedated, under-supported? And number one probably is to get rid of the ventilator. If you get rid of the ventilator, you don't have to worry about ventilator-induced lung injury. With that, I'll wrap this up. My contact information is lambrrt@gmail.com. You can reach out to me. I'll be happy to send you my slides. And www.inspirert.com, again, is our nonprofit organization that we developed to sort of provide educational opportunities in an attempt to close that gap between the science and bedside clinical care. So thank you very much. I appreciate your attention.